Clinical features, mainly it is a epigastric swelling, then upper abdominal pain will be there, then anorexia and weight loss will be there, then care sign we will tell later, and dyspepsia, nausea, vomiting. These are the main clinical features. And on examination, how the cyst will be, it will be a hemispherical, smooth, soft, not moving with respiration, and not mobile swelling. Its upper margin will be diffuse, but its lower margin will be well defined. And on percussion, resonant or impaired resonant node will be heard. And once the cyst is becoming infected, then it will become a tender mass. And along with that, the features of infection like fever, chills, etc., will be developing in the patient. That is, once it is getting infected. Investigations, we can go for USG abdomen, CT scan, MRCP, ERCP, barium meal X-ray, then LFT, serum amylase, platelet count, PTINR, then EUS guided aspiration, that is for analyzing the fluid that can be done. So these are the major investigations that can be suggested. And the treatment, mm, we have already told, it is classified into acute and chronic pseudocyst. So in case of acute pseudocyst, usually it will resolve without any treatment. But then also, if it is required, surgical, means surgery is indicated when after 6 weeks also, if it is not getting resolved on its own. If the size of the pseudocyst is being increasing, means 5 to 6 centimeter, more than that it is increasing, then if there is a chance of secondary infection, or if there is an evidence of secondary infection, or if there is any other complications being developed, in such conditions we can go for surgical treatment. Otherwise, it is told that acute pseudocyst will resolve without any treatment. And in that condition, the treatments told us internal drainage, excision of pseudocyst, and external drainage. And internal drainage, three options are there, means cystogeginostomy, cystogastrostomy, cystoduodenostomy. That is drainage, means different anastomosis is being created for the drainage. So cystogeginostomy is the most preferred technique. And cystogastrostomy means drainage is done into the stomach. Cystoduodenostomy is drainage into the duodenum. Similarly, cystogeginostomy, it is into the jejunum. So based on that drainage into which or the anastomosis where it is created, three options are there for internal drainage: cystogeginostomy, cystogastrostomy, and cystoduodenostomy. And among this, cystogeginostomy, cystogeginostomy is the most preferred technique. And next procedure is internal, means excision of pseudocyst. First was internal drainage, next is excision of the pseudocyst. And here means in most cases it is hardly required, and it is usually limited to the pseudocyst involving the tail of pancreas. When the pseudocyst is involving the tail of pancreas, this excision can be done. And that can be the procedure which can be taken as distal pancreatectomy. That also with or without splenectomy, according to the condition, it can be done with or without splenectomy. That is, distal pancreatectomy is the procedure, means excision of pseudocyst can be done with that procedure. Then next treatment, it is told like third option is external drainage, and that is required when there is gross infection, that is already a grave patient it is, and when there is mm, mm, so much of infection and we cannot go for any surgery. In such a condition, we can go for external drainage. That is the three procedures which can be advised in case of uh, acute pseudocyst, that too uh, when it is not resolving, when surgery is indicated. And in chronic pseudocyst also, there will be maturity of the cyst wall in case of chronic pseudocyst. And in that, elective surgical management of chronic pseudocyst is advised. And there are also three methods are told: external drainage, excision, and internal drainage. That is about the pseudocyst. So pseudocyst mainly what it is? It is the encapsulated fluid or blood in the lesser sac or the peripancreatic structures. And next, it is the etiology. What are the causes? It can be due to trauma. It can be after any kind of means operations or after a few attacks of pancreatitis. Then we have to see what are the types. Based on its communication with the pancreatic duct, it is divided into two, and communicating and non-communicating. And based on the onset, it is divided into two. That is acute and chronic, the clinical features, and then the treatment. Acute case, it is told that it will resolve on its own without any treatment. But if it is not resolving, if the size is increasing, if there is any complications developing, then we have to go for surgical treatment. And surgical techniques for acute and chronic, it is told three methods are told: excision, external drainage, and internal drainage. Next, we will see about the true cyst of the pancreas. So, true cyst of pancreas is classified as congenital and acquired. Mean division it is like that. And in congenital comes single cyst, multiple cyst within the pancreas, then simple cyst of pancreas associated with the polycystic disease, then fibrocystic disease, dermoid cyst, etc. Then acquired, in the acquired category comes the retention cyst, parasitic cyst, and neoplastic cyst. That is the main um, classification of true cyst. And in that, the congenital cyst, we have already seen about the congenital cyst, that is the congenital cystic condition of the pancreas. It is rare and it is associated with congenital cystic disease of liver and kidney. Fibrocystic disease also we have seen because of the, it is an abnormality of all mucus secreting glands, particularly of pancreas and bronchioles. We have seen the clinical features, the investigations which have to be done, and the treatment also. And in case of acquired cyst, the retention cyst, it can be unilocular or multilocular. It will be having communication with the duct, pancreatic duct. And this type of cyst is due to ductal obstruction by chronic pancreatitis, stone or tumor. Due to that ductal obstruction, that is being developed. Because of that, retention is happening. So there is a reason for that retention, and that is mainly a ductal obstruction. And this will extend beyond the pancreas. And inside the cyst, mainly it will be the clear pancreatic juice. And in the juice, it will be containing all kind of pancreatic enzymes that can be detected. And in this condition, it can be means there will be the wall of the cyst will be um, containing the pancreatic substance. There will be fibrotic degeneration and all. So there will be the wall of the cyst will be containing incrustation of pancreatic substance also. That is about retention cyst. Mainly it is unilocular or multilocular. It will be having communications. It will be due to the ductal obstruction. And parasitic cyst, it is told the hydatid cyst of pancreas, it is rare. And if it is present, it can be treated by enucleation. Then if the cyst is large, if it is involving tail or body, then distal pancreatectomy with the splenectomy should be performed. Then it is neoplastic cyst. Neoplastic cyst, that is the cyst from cystadenoma, or it will be lying in the adenomatous mass. In that condition, excision is preferred, and means there will be a narrow attachment to the pancreas. So the excision will be easy also. So the suggested treatment is excision only in case of neoplastic cyst. Commonly, if we consider the cyst, the clinical features, it will be epigastric discomfort, swelling, and all. That will be the main features. And the treatment, when the cyst is situated at the tail of the pancreas, we can go for distal pancreatectomy. Otherwise, internal drainage can be done. And if a large cyst is present at the head of the pancreas, cystoduodenostomy is told. And if the large cyst is present in the body, cystogastrostomy is told. So that is the treatment. Depending on the location, the treatment is mainly told. Next is about the neoplasm of the pancreas. Neoplasms of the pancreas can be broadly classified into two groups: carcinoma of pancreas, and next thing is neoplasm of the islet cells, that is, which is concerned with the endocrine secretion of the pancreas. So, broad classification is that carcinoma of pancreas and neoplasm of islet cells. And first, it is about the carcinoma pancreas. So, means some factors are to which will provoke the carcinoma of pancreas or carcinoma, like cigarette smoking, consumption of coffee, diet rich fat, certain chemical agents, diabetes, then carcinogens in duodenal contents, alcohol ingestion. These are the provoking or initiating factors for carcinoma of pancreas. And another thing, it is told that there is a fair standard distribution of the carcinoma of pancreas. That is, it is told that in the head it will be 60 to 80%, in the body 15 to 30%, and in the tail 5 to 10%. That is the standard distribution of the carcinomas of pancreas. First, it is about the First, it is about the carcinoma of head proper. We have already told it is divided into carcinoma of head, then body, tail. So first about the carcinoma of head proper. Adenocarcinoma. It is the predominant lesion of carcinoma head. The tumors may be mucin. Lesion will be small. Usually it will be small, and if there will be irregular nodularity present, the carcinoma will be looking grayish white, serous or homogeneous tumor. That is, from the yellow lobular structure of pancreas, there is a variation. It is the yellow lobular structure is replaced with the grayish white serous or homogeneous tumor. That structure will be replaced. Then this tumors will compress the pancreatic and common bile duct, and it's based on the compression caused by this, the symptoms will be appearing. Then, as a consequence of the obstruction of the common bile duct, the bile duct proximal to the obstruction becomes distended along with the gallbladder, and the gallbladder will be distended and it will be palpable. So that is the consequence of the compression caused by this tumor on the pancreatic and common bile duct. Next, it is about the carcinoma of the ampulla of Vater, periambulary. That is, it will be columnar cell adenocarcinoma. It will be arising from the duodenal papillae in the ampulla of Vater or in the duodenal mucosa adjacent to the papilla. There will be an area of pancreatitis in the head of pancreas. The primary lesion will be palpate. In this carcinoma, in such carcinoma, jaundice may not be progressive. Means there will be sloughing happening. So because of that sloughing, that jaundice will not be that prominent in these conditions. That is about the carcinoma of ampulla of Vater. Then next is about the carcinoma of body and tail. So these means, when we said about carcinoma of head, we told that the tumors are usually small. But in this case, in the body and tail, the tumors are usually large. It will be hard, irregular masses, and means these carcinomas frequently extend more widely. Means than that of the head. Means in the carcinoma of head, that much extension was not told. But here, in this condition of carcinoma of body and tail, they will extend more widely, and they will impinge upon adjacent vertebral column. They will extend through the retroperitoneal space upwards and downwards, and it will sometimes invade the spleen or adrenal also. The spread it is told. Then they will extend into the transverse colon, stomach. There can be lymph node metastasis, liver metastasis will be there. So the extension is more when compared to carcinoma of head. Then the spread is told. Spread, that is told like Local spread we have told, means the adjacent organs are being involved. Then lymphatic spread from the body, tail, and head, it will move to the pancreatic or duodenal group, lymph nodes at porta hepatis, hepatic group of lymph. So many adjacent lymph nodes are being easily involved by the lymphatic spread. That is another. So first one is local spread, next is lymphatic spread. Then vascular spread, when we consider with others, it is extremely uncommon, but still liver is being affected through such spread from the body and tail. The liver is being affected through this vascular spread. Then another thing is peritoneal implantation, resulting in ascites. That is the four types of spreads: local spread, lymphatic spread, vascular spread, and peritoneal implantation. Now it is about the clinical features. Clinical features, two type of presentation are usually seen. One is painless, progressive, obstructive jaundice. Another one is intractable pain without jaundice. So first one, in the painless, progressive, obstructive jaundice, mainly this type of feature is present in carcinoma of head of pancreas. Head of pancreas is the main region in which this painless, progressive, obstructive jaundice will be present. And this progressive jaundice, it will be usually associated with the pruritus. Then the jaundice will be progressing like that. Means it will be progressing steadily until the patient is almost green in color. That much jaundice will be happening to the patient. Pain is not a marked feature. We have told it is a painless condition, but then also when it is carefully inquired for, means when we are inquiring it so carefully that the patient will complain of a dull aching pain. It is not that severe or that colicky or that much intense pain. It will be a dull aching pain in the epigastrium. There will be the patient, when inquired carefully, they will be telling that there is a radiation to the back. Pain will be radiating to the back or to the both lower quadrants also. And same thing, means in sitting position it will be relieved, and in supine position it will be aggravating. Eating also will aggravate the pain. That is, even though the pain is not a marked feature, but when we carefully inquire, the patient may complain of dull and aching pain having these characteristics. And other than jaundice and pain, there will be weight loss. Means in any part, whether it is head or body or tail, weight loss is a common symptom of carcinoma of pancreas. Then other than that, anorexia, then diarrhea with the pale and foul smelling stool, then steatoria, these also will be present. And on examination, jaundice will be present, palpable distended gallbladder will be present, and enlargement of liver also will be present on examination. That is the first type of presentation, painless, progressive, obstructive jaundice. Next is intractable pain without jaundice. So such pain is often noticed in case of carcinoma of body and tail of pancreas. The pain is intractable and mostly referred to the epigastric region with radiation to the back. And the pain, same, it will be aggravated on lying down, it will be relieved in sitting posture and leaning forward. That stooping posture, it will be relieved. Other than pain, and there will be loss of weight, anorexia, diarrhea, chills and fever. Diabetes mellitus is often accompanied with the carcinoma of pancreas. Then on examination, there will be generalized wasting, liver will be palpable, splenomegaly can be found out. And in case of carcinoma of ample of water, some peculiar symptoms, it is told that pain will be less frequent in this condition, and but when it is present, it will be colicky in nature. Intermittent jaundice will be present, chills and fever also will be present due to cholangitis and all. There will be chills and fever also accompanied in this condition. And that is the presentation in case of carcinoma of ampulla of Vater. Then investigations is same, that is serological markers for carcinoma, then radiography, ERCP, USG, CT, then fine needle aspiration biopsy. These are the treatments told. Then treatment, sorry, that is the investigations tool. And in treatment, mainly it is told that Treatment of carcinoma of head of pancreas. It is told like once the diagnosis is established, once we are clear about the diagnosis, the treatment is early operation. And before the operation, adequate nutrition, correction of anemia, the renal function evaluation have to be done. That is pre-operative evaluation of renal function have to be done, because post-operatively there can be a renal function impairment. So for that, pre-operative evaluation have to be done regarding the renal function. Then procedure, it is told that explore the abdomen through a right paramedian incision, um, extend downwards, and then the regional knots can be removed and it can be given, sent for biopsy. And once the diagnosis is established, then the next step is to determine the feasibility of radical excision. And when the distal lymph nodes are not involved, when the tumor is not fixed, and when the liver is free from metastasis, we can go for radical surgery. And when the tumor is less than 3 centimeter, it is considered as resectable, but those greater than 5 centimeter are not resectable. Resectable tumors, it is told, it will be situated near the ampulla, and tumors in the body of pancreas that are mostly unresectable. So once the diagnosis is confirmed, we have to see for all these things, how the tumor is, whether it is resectable or whether it is non-resectable, whether we can go for a radical surgery. That all have to be confirmed after the diagnosis is made. And means when resection is possible, it is told that uh, the head and neck of the pancreas together with the duodenum, means we are telling about the carcinoma head. So when that portion, the head and neck of the pancreas together with the duodenum, we can resect. And that procedure is called pancreaticoduodenectomy, or it is called Whipple's operation. So that is the main treatment told in case of carcinoma head of pancreas. Whipple's operation or pancreaticoduodenectomy. The head and neck along with the duodenum portion that is being removed. And other operations are also told, like total pancreatectomy and regional pancreatectomy. That are the surgical operations. Then palliative surgery is also told. Palliative means there will be pain associated with the tumor. The tumor associated pain should be relieved. Then biliary obstruction infection, that also have to be relieved. So these three are the palliative surgery. Means main surgeries we have to go to the disease as such. Whipple's operation, total pancreatectomy, and regional pancreatectomy are the procedures. For palliative surgery to alleviate duodenal obstruction, and for that. For that, first thing, pain, it can be controlled by strong analgesics. Then chemical splanchnicectomy it is told. Then pancreatic duct can be dilated, and that can be as anastomosed with the back of the stomach side to side, and that also will